So here's all of our diagnostic tests that we can do, right? And we're going to combine our symptoms on there also, because they kind of go hand in hand. We got symptoms and we have diagnostic tests, right? So systemic inflammation, right? So that's going to cause a surge response, a systemic inflammatory response, right? So that is how many surge responses you need to officially have sepsis. You only need 2. And what are they again? You got heart rate, you got temperature, respirations, and white count. Which one of them can be low? WBCs or temperature, right? So you got a fever plus an SNS response basically, right? And then we can do a CBC. Usually these people are really sick. They're going to get all the labs done. We call that a rainbow, right? We get all the labs of the rainbow done, right? So a CBC, a chemistry, and a coag, right? Also, we might do troponin. We might do some other fancy stuff too, but CBC and coags. And also we're going to hit them up with a lactate level, right? Because we can measure lactate, and then the lactate, if it's high, will tell us that the organs are doing great or not so great. Not so great, right? So altered, especially in the elderly we mentioned, right? All that widespread inflammation. And we can assess someone's perfusion. Are they perfusing good? Lactate's a great way to assess if someone's perfusing, because if it's really high, they're not perfusing the organs great, right? If it's borderline, like 2.5, they're in trouble. We got to turn that around. We're going to do a repeat lactate to make sure it's going the right direction. If it's like 1.6, not going to care. We're not going to not care, but we'll continue to monitor, right? So we're going to do the things in the right order. We're going to do antibiotics. We're going to do fluids, all the things we would normally do, which we'll talk about on the treatment page, right? So greater than 2, you pretty much have what kind of sepsis? You have severe sepsis. How do you get septic shock? Greater than 4, all right? So poor perfusion is a red flag, right? If you have poor perfusion, lactate is really high, you have skin that's cold. And actually, they've done studies that show that modeling is a really good indicator of someone's perfusion status, right? So cap refill, yeah, but as far as modeling, yes, definitely. What's the difference in modeling and cap refill? So cap refill is the perfusion of the nail beds and such, right? Whereas modeling is the skin actually dying on you, right? So they can look at the kneecaps, and they compared from the kneecaps, you're getting more and more and more spread, right? So it goes from here to here, right? That one, the one with the more widespread modeling, is much more concerning, right? So you got a low blood pressure, low BP, that's going to be a sign of poor perfusion as well, right? You may even be going from severe sepsis to septic shock, right? Because when they have severe sepsis, we want to try to fix it, right? We try to fix it with fluids, usually, okay? So how do you assess our organs dying, right? Our organs not getting the perfusion they need. So the chemistry will tell us the creatinine, right? Yeah, you could see if the potassium might be elevated, but there might be other reasons. Maybe they took too much of their, I don't know, too much of the spironolactone. I don't know. But definitely if your creatinine's going up and the urine output is poor, that is a sign that your kidneys are failing. And what is poor urine output? It's oliguric, right? That means and what is oliguria? How much urine output should you have every hour? About 30. That's perfect if your patient weighs 60 kilos. Right, patient weighs 60 kilos. How many patients do you know weigh 60 kilos? Not many, right? So you go back to pediatrics, and this is what all the kidney societies have decided on also. You have to go 0.5 per kilo. So you have to have at least 0.5 per kilo. So they're 100 kilos. How much urine output should they have per hour? They should have 50 mLs per hour, right? They're 100 kilos, which is 220, right? 220 is not hard for a lot of our patients to meet, right? So, and also just statistics, obesity is going up and up, so it's going to be, we have to assess 0.5 per kilo, okay? Liver failure, we mentioned with labs and liver failure, the T-billy might go up, that might shut down, AST, ALT might go up. All these things are signs that our organs are failing, right? So we got hematological failure, we mentioned, the coags are getting elevated, right? The PGT is going up greater than 60. The INR is going up. The this platelet count will go down. Why is the platelet count going down? Because you're consuming them. You're making clots. Why are you making clots? They're not bleeding. Because the inflammatory process, right? When you have an inflammation, right? When you stick a nail into your finger, right? You want it to, and you're bleeding. You want it to clot off, right? What makes it do that is A, the collagen there, but also B, the inflammation that's there. That will prevent you from bleeding out. Right? But if you have all those inflammatory mediators throughout the whole body, you're going to clot everywhere. Okay? So identification. So there's like sepsis, because you could have SIRS, right? You could have acute pancreatitis, you could have these other things, but more commonly it's going to be an infectious source, right? And how do you identify that someone has a sepsis? You do, again, all the labs. We can look at other, like the CBC and chemistry and such, but we're going to go just think head to toe. This is an order of most common to least common, but so most commonly people come in with pneumonias, right? So how do you know someone has a pneumonia? They have an X-ray that's not clear, right? So there's something on X-ray. They could have CHF, but usually X-rays, they look what looks like cotton balls, and those are infiltrates, right? They're usually on one side or the other. They have a severe pneumonia, it could be on both sides, but usually it's on one side or the other. They have sputum that's productive or non-productive. It might be green, it might not be green, right? They might have dyspnea, right? What is dyspnea? They got shortness of breath. If someone's on oxygen, like 6 liters of oxygen, right? And they come in with sepsis, that might be the source, right? Unless they're on oxygen at home, but we're not going to get that complicated. They're on oxygen, they probably have a pneumonia, right? But we have to do the test to look to see if that's true or not, right? One of the tests would be an X-ray. And what's another test you would do to see if that pneumonia has spread to the bloodstream? You can do a blood culture, right? So blood cultures will see, as worst case scenario, the infection has made its way to the bloodstream, and now it's going to start going to severe sepsis, causing more organs to shut down, to septic shock, all the way to a bad situation, right? So UAs. So you talked about UAs in Med-Surg 1 and your analyses, and what tells you have a UTI? They got leukocytes don't 100%. You can have what's called sterile pyuria, where you have white blood cells, but you don't have a UTI. So what's 100% tells you have, or like 95%, is you have a leukoesterase or nitrates that are positive. Those tell you that 95% wise that you have a UTI, right? Because what do bacteria produce? Nitrates, right? So there's nitrates positive. It wasn't you, it was bacteria, right? Leukoesterase is the enzyme that's inside white blood cells that chews on bacteria. Okay, so if those are present, right, your white blood cells just don't go down there and just start chewing, like having snacks. They only snack on bacteria. But what are some symptoms? So that's like the lab test you can do. But what are some symptoms of someone that has a UTI? They got dysuria, they got urgency, frequency, right? So the mnemonic is FDUF, right? So FDUF, you got flank pain. Right, you have fever, dysuria, urgency, and some pyuria. They might have some purulent, smelly urine. Okay, but that's not guaranteed. People do have smelly urine. They might have had asparagus. You don't know. All right, and about CT abdomen. So going from head to toe, like most commonly, is going to be a pneumonia, but then next will be a UTI, very common, and after that would be something abdominal. And it's really hard sometimes to pinpoint what's abdominal. So we do a CT of the abdomen. The CT is going to go through the whole abdomen, and while they're there, they might get a CT chest also to see if there's pneumonia. But they'll do the CT abdomen to see if there is some abdominal process, if there's something brewing in the abdomen. Is there a perforation, right? Is there, and if they had peritonitis, perforation of peritonitis, what signs would there be for peritonitis? They have a rigid board-like abdomen, right? They have diffuse abdominal pain versus just like one area. Okay, so they might have an obstruction. How does an obstruction lead to sepsis? It's a small bowel obstruction, right, or a large bowel obstruction. Things can't go forward, then the bacteria are going to start to percolate, right? Bacteria love static environments. They're going to percolate, and they're going to inflame the colon or inflame the small intestine, and eventually they're going to translocate. They're going to go from one area to the bloodstream, which is next, right? So that could cause a sepsis or severe sepsis or septic shock, right? So we're looking for obstruction or perforation, worst case scenario. They could have diarrhea, right? Diarrhea can be infectious, and the diarrhea we're going to talk about today is C. diff diarrhea, right? So C. diff can be very, very deadly, and we want to make sure that we capture it, right? We got to culture it. Okay, so where is the pain? Is it in one quadrant over another? That's going to kind of zero you in to see what it might be. And we mentioned with gallbladders last week that ultrasounds are actually better than CT scans. So it might do ultrasound of the abdomen to look for a gallbladder or something or other, right? They can also look for the appendix with ultrasounds, but CTs are okay. All right, and then next step, we're going to look to see, well, do they have a osteomyelitis? Do they have a soft tissue infection, right? So they have a soft tissue that's inflamed. Has that tissue gone so inflamed, like it's a decubitus ulcer or it's a abscess, has it gone all the way down to the bone or not? Because if it's gone to the bone, it's really hard, A, to treat bone infections, but also B, that your bone's very, very vascular, and that can easily create a septic shock, right, or a sepsis situation. Okay, so we have an MRI. MRI is great for looking at soft tissues. So an MRI will be there to look to see, is it just cellulitis or is there a wound that's caused osteomyelitis? Okay, and how do you know someone needs an MRI or someone might have sepsis from their wound? Well, A, they have a wound. B, it looks bad, right? And they could have cellulitis, which is red inflammation, right, through that area. It can even be necrotizing cellulitis, which is where it starts turning dark and starts spreading by the hour, right?
Like gangrene.
Mm-hmm. And that's life-threatening. All right, anyways, inflamed joint. So you're looking to see what's hot, right? If something's hot, that's the source of the sepsis, right? So you look for any kind of joints that might be red or swollen, right? So they have a swollen red knee. That could be what's called septic arthritis, right? And then ascites, we talked about last week, right? Ascites, if someone comes with ascites and they're infected, it probably is going to be SBP, or spontaneous bacterial peritonitis, right? So they got diffuse abdominal pain, they got guarding, right? And then it's supposed to say purulent. So purulent, when they pull out the acidic fluid, it's all purulent, it's not clear. That's a sign you might have SBP. So if they got plastic in the patient, right? They come from the nursing home with a Foley for the last 45 days and a PICC line for the last year. That might be the source of the infection. So we have to culture it for one, but also we should take plastic out of the patient, right? There's also in the hospital setting, you have like Foleys in just for a long time, or a JP drain that's in too long. We have staples that are in for more than 7 days. We have all these things that can lead to problems, right? So we want to take away those problems as a source of infection. Okay. And then if it gets in the bloodstream, right, if you get an infection in the bloodstream, it can spread through the whole bloodstream and it can start to park itself onto the valves. And if it parks itself on the valves, that's called endocarditis, right? So endocarditis could be a problem that we can assess with a murmur. If they have a murmur, then you have endocarditis. We can do what kind of diagnostic test to see if someone has a endocarditis? We can do a echo. EKG won't tell you much. It might tell you if someone has pericarditis, right? Which could be like why, due to inflammation and such. But they got a murmur. They have a rub, right? Rub is leaning more towards pericarditis. All right, so all these things are signs of the heart is now infected, right? And then neuro symptoms. Again, neuro is like the last thing we'll look at. Yes, they're going to be altered the whole time, but there's a lot more things. You're not going to say, oh, it's meningitis, right? It's usually something else that caused it first, right? But if all the diagnostic tests were negative, all those labs were great, then it could be meningitis. And how do you assess if someone has meningitis? You stick a needle in them, right? So you put a needle into the spinal cord, or not into the spinal cord, into the spinal space, and you pull out some CSF and you sample it and you see if they have an infection or not, right? Also, meningitis has unique symptoms. You'll learn in pediatrics and such where you have a nuchal rigidity. What does nuchal mean? It means it's a stiff neck, basically, right? And they got photophobia. What is photophobia? They got sensitivity to light. They want the lights off all the time, right? So yeah, so these are all the diagnostic tests we can do for someone who has sepsis, right? And then very important is what if you assess the blood to make sure it's not gotten to the blood, and that's where you do a blood culture, right? We're gonna do the other things too, but blood cultures are also needed, and we want to do that before antibiotics, right? Sometimes you can't get IV access, or you couldn't get, they're like a really difficult stick. There are exceptions, but for the exam, we want to make sure we get antibiotics done before or after cultures.
Before.
Antibiotics are done after cultures, right? All right, so then we'd also do what's called pan culturing. So we're not only going to test the blood, but we're going to test the other things, test the sputum, test the urine, all those things, test the wounds. Another little fancy test we can do that's now at both hospitals is procalcitonin, and that will tell you if someone has a bacterial infection or not. It's a magic test. So you got bacteria, right? It doesn't tell you about viruses or other things, but it's a procalcitonin. It's involved in the sepsis response, all that inflammatory cascade. If we have that value is more than 0.5, then you have a bacterial infection, right? So it lets you know if you have bacteria, but also can let you know if antibiotics are needed anymore. Yes?
They wouldn't start a wide spectrum or something like that prior to getting culture results back.
It's only if they can't get the cultures immediately. Okay. So definitely you need to get antibiotics on board within the first hour, but you need to get the cultures before that. Okay. Right, that's the priority. Okay. So these are the examples. And there's other infectious sources. All these little things make sense going from most common to least common, but when we talk about antibiotics, they don't talk it like this. They talk in this language here. So you got a pneumonia that you got in the hospital, or you got it outside the hospital. So it's community-acquired pneumonia or hospital-acquired pneumonia. And the UTI. A UTI is either in the hospital or out of the hospital, right? So it's either complicated or uncomplicated, or community-associated or hospital-associated. And the other ones are pretty straightforward. An SSTI is not an STI, right? An SSTI is a skin and soft tissue infection, right? STIs rarely lead to just like a widespread sepsis. Have to like not treated for a long time for that to happen, all right? But SSTI, skin and soft tissue infection, we have a wound that's is infested, and that we need to start the right antibiotics for that wound, all right? And then we have abdominal sepsis. So that makes sense. We got something in the belly that's causing a sepsis. And these different bacteria affect different areas. This is where you have to bring in your micro, right? Like what bacteria affect the lungs? What bacteria affect the wounds? What bacteria is all over our skin, usually, that causes disease? E. coli. Not E. coli. It better not be E. coli. Staph, right? Staph's on your skin, and staph can become MRSA. That's methicillin-resistant Staph aureus, right? Methicillin being a penicillin, right? So it's Staph aureus that does not respond to the penicillin. Where is E. coli? Not on your buttocks. Hopefully not. You've wiped decently. You use your bidet, right? It's inside the colon, right? That's E. coli, right? If it makes its way over to the urinary tract, then now you have a UTI, right? E. coli being the most common, okay? So yeah, so abdominal sepsis are a lot of gross things in the abdomen. So there's a lot of things we got to give antibiotics for to cover those sources, right? And then we have unknown. Sometimes you can't figure it out, right? So we do broad spectrum antibiotics. We do antibiotics that cover everything basically. And really it's going to be defined whether they're going to the ICU or they're like going home, right? And usually if it's unknown, you're usually going to get hospitalized and we have to start all the big guns, right? And there's different guns out there. There's ones that are just handguns and ones that are tanks, right? And you don't want to be giving the tank at every patient, otherwise what happens? You develop super bugs, super bacteria, things that are going to be immune to the tanks, right? And now you have, we all saw The Last of Us, all right? So yeah, so most common source of sepsis, right? Pneumonia being way up there, right? So pneumonia being super popular. And then we got UTIs coming up next, and then progressive from there. All right, does that make sense as far as how to figure out where the sepsis is? And why is this important? It's like, I'm not a doctor. Well, it's to assess, maybe the doctor not, how many doctor assessments have you seen? They go in the room with how many stethoscopes? Sometimes there's stethoscope. Sometimes they write a note from the third floor. It's like, whoa, you saw the patient? Whoa, I didn't see you. All right, so not to say all doctors are like that, but sometimes that happens. And we are the ones that are there 24 hours a day. The doctor's there for 2 to 30 minutes, and they don't assess. They might be able to assess the whole patient. And then sometimes they're overworked. They got all kinds of patients, all kinds of other politics going on. But either way, we're there 24 hours a day, so we have to assess, hey, this knee is super hot, or hey, they're complaining a lot of pain. I got Miss Smith up, and she has a really difficult time starting a urine stream. Does she have a swollen prostate? No, she does not. Right? So there's all kinds of different other things that could cause that could be signs of a UTI. Okay. Or she has ascites and like that belly, that she have a diffuse abdominal pain, right? Or she had pain that started in one corner and now it's going everywhere in the belly. We're there 24 hours to assess those things. And we have to ask for the next thing, right? And SBAR communication is you put a little recommendation out there, right? All right, so the treatment, how do you fix sepsis? So we say, congratulations, you have sepsis. How do you know you have sepsis? You got two SIRS signs, and you got a source of infection. So you got a UA that's positive, or you have an X-ray that's positive, or you have, like symptoms that really kind of convince you that is like they have a right upper quadrant pain, they got a Murphy's sign, they're all yellow from head to toe, they probably have a gallbladder issue, right? So if that's the case, to come to the hospital, the clock starts when they hit the door, or when we discover it technically, and you have 1 hour to do stuff. In that first hour, you have to get lactate levels, right? You got to get blood cultures. So usually when you do a blood draw, you're going to grab all the labs, right? So you get all the things. And we're going to do broad spectrum antibiotics after cultures, of course, right? So and every hour we mentioned that you wait, it's like an 8% chance of dying, right? So we want to make sure we get it hour 1 versus hour 3 or hour 6, right? We want to get the antibiotics on board because they have this widespread inflammation that's coming from the bacteria, and the only way you're going to fight off that infection is by killing the bacteria because they're going to mount their own immune response, their own war, right? Their white blood cells are going to attack the bacteria, but the bacteria are a 10 and their white blood cells are a 4, let's say, let's make them normal, right? We want to take the bacteria down to a 4 also, so it's a fair fight. So we got to give the antibiotics to cut out the bacteria, right? The other way that we can cut out the bacteria is take out the source of infection, right? You can't take out someone's bloodstream, unfortunately, right? But you can take out an abscess, right? If they have a gallbladder that's oozing bile and all kinds of bacteria into the abdominal space, take it out, right? And you get surgery at that point, right? So there's things we can do to fix the source of to fix the sepsis, okay? So fluids, and fluids are somewhat controversial, but 30 per kilo is what we have to bill for. So if we don't do it, then we follow compliance. So there's a whole thing on fluids, but 30 per kilo is what you want to target, right? That's still a recommendation. This will probably be changed in the next 1 to 2 years. But you want to give, if they weigh 100 kilos, how much is 30 per kilo? 3,000, right? 30 times 100 kilos is 3,000, right? So you had to give them 3,000 mLs of fluid, right? So why is that controversial? Well, what we said the vessels were what? Super leaky, right? If you give 1 liter of fluid, 95% of it goes into the interstitial spaces, and that makes them swollen and makes them not function good. So it makes the pancreas not function good, it makes the gallbladder not function good, it makes the organs start failing, right? So it used to be you need to pee to swell to get well and pee to be free. Peeing is great, but you should not have to get so many fluids. Usually no more than 2 liters, especially if they are end-stage renal disease or CHF. They can't really tolerate all those fluids. On a good day, if you don't have sepsis, how much of a liter of saline gets into your vascular space?
75%.
Good guess. 75% of it stays where? And either go into intravascular space or does it leave the intravascular space and go into interstitial spaces? So 75% of it leaves. So when you give 1 liter, 250 of it stays in the bloodstream, 750 goes out in the interstitial spaces, right? So it's not, that's on a great day, on a perfect patient, right? When you give 1 liter to a patient who's septic, 95% of it leaves into the interstitial spaces. It does not restore, it doesn't fix the underlying problem. The underlying problem is the inflammation, right? So that's why steroids make sense, right? Steroids are anti-inflammatory, right? And they are going to, and we're going to give IV ones. Those are the IV ones right there: methylpenisolone, hydrocortisone, dexamethasone. Dexa being the strongest steroid we can give IV. And those ones are going to fight off the inflammatory response, right? And vasopressors, again, if they start into a shock state, you talk about more about septic shock in Med-Surg 3, but this, you want to make sure that they are, that's a complication that can happen. And how do we fix that is with vasopressors. Those are examples of them, but you don't have to know those ones. That's where you get to know those in next semester. Okay, so we can do all those things, but how do you fix it, right? How do you, if you can fix it, you got to give them a D, all right? You got to drain it, right? So if they have a gallbladder that's oozing, put a drain in it, right? You got a wound that's crazy purulent, you got to debride it, right? If they have plastic in them, take the plastic out, right? So device removal, all right? And definitive measures. So definitive measures means surgery, right? Or you have to do something definitively to take out the source of infection. Okay, so these are all examples you might do. You might, if they have like empyema, put a chest tube in to take out all that purulent fluid inside their chest, right? They have an SBP, you're going to take out some of the acidic fluid, but really you're going to, in that case, you need to give antibiotics and albumin. Either way, that's the goal, right? Is to take out the source and then, of course, give them the tools to fight off the infection, right? Which includes antibiotics, right? All right, so complications of sepsis. So we kind of mentioned some of these already. We got organs can fail, and that's called multi-organ dysfunction syndrome, right? So MODS, we have 2 or more organs have failed, right? We have a creatinine that's elevated, so we got a creatinine right here. Kidneys are not looking good, right? So we got a creatinine that's greater than 5. That's not great, right? We have a coags are not good, right? So they are a really, really high bleeding risk, right? The liver is not great. The CNS, the GCS is less than 6, right? That is not a good situation. That means 2 organs have failed, and the more organs that fail, that's called the sequential organ failure assessment. But that's what doctors and Medicare and everybody uses to assess how bad is it, right? How bad is their sepsis, right? And we mentioned that sepsis is the #1 reason for hospital readmissions. So you may recover from your sepsis event, from your septic shock or your severe sepsis, but basically your recovery is going to be on the downhill. It's really, really hard to get back to normal, right? There's you have pneumonia or like long COVID, for instance, right? COVID has a huge surge response, and now some people have long COVID. Now they have pulmonary fibrosis, and they have dyspnea, exertion. They have all these long-term consequences, right? They never really fully make it back to their level they were pre-infection or pre-SIRS, and now they are at risk, right? They're weaker. They don't have an IS at home. Shame on us, but they don't have an IS at home, so now they have more atelectasis. They can get pneumonias, right? They want to be bed rest. They want to lay down all the time. Now they have bone breakdown, but also they have decubiti that can form, right? They get UTIs. All these things can be consequences of being septic, and of course, when you're elderly, when you're obese, when you have I said elderly already, but you have diabetes, all these things are going to compound your ability to recover from sepsis, right? So it's a downward spiral when you have a sepsis. You can see, on average, about 50 to 70% mortality, which is not great. That's like after you make it, that's like a 1 year, 5 year outcome, right? And pancreatic cancer, or I think like esophageal cancer is like 50, 60%. So it's almost like getting a cancer diagnosis, having sepsis. Okay, so here's a good point is you got 11 points on this scale. So you got a 4 here, we got a 4 here, and a 3 there. Right, it's 4, 8, 11 points. Guess what your mortality is? 90%, right? 9 out of 10 patients that have 11 points, 9 of them die. So it's an incredibly worrisome situation. Okay, so we talked about we got SIRS or sepsis. Those guys are intertwined, right? The only difference between those two is what? A source of infection, right? And they have to have those 4 criteria mentioned, or 2 of those 4 criteria. And then we can progress to severe sepsis, and then septic shock, multi-organ failure. And one of the organs that can fail is the hematological system, which is DIC, right? So DIC is disseminated intravascular coagulopathy. We talked about the dysregulation. Basically, you're clotting so much because your inflammatory cascade, that's what it's designed to do. But it's not designed to do that widespread through the whole body. Okay? So that's the idea with sepsis.
It's beginning to look a lot like sepsis when the BP's low. Heart is racing and brain is dim. Send a lactate on ice and then place central lines, 'cause Santa's dying without Vanco. It's beginning to look a lot like sepsis when the temp is high. CBP is way down again. Give a bolus or maybe 10. Ain't no silent night. A pair of blood cultures, then a UA and chest film is the list of tests to begin. Entering them in the EHR can be an hour of clicking, and then the whole thing freezes. Jesus, start that order set again. It's beginning to look a lot like sepsis. Hang the dang Neo. Time is clicking down on the clock when Santa's got septic shock. All he wants for Christmas is some urine flow. It's beginning to look just like malpractice when you miss the signs. Early management is the key if Santa is to see another Christmas time. Hey, give old Saint Nick some.
Recording in progress.
All right, so the Wi-Fi is a little bit janky today. I'm sorry about that. All right, so yeah, so let's take a break and we'll come back for more sepsis. All right, so apologies for the Wi-Fi. Of course, the video is available on your PowerPoint. I try to mix it up so you don't have to hear my voice the whole time. All right, so we're doing DIC. So DIC is a complication of sepsis, right? So we have a patient that has widespread inflammation, therefore widespread coagulopathy. And another word for widespread, fancy word wise, is disseminated. All right, so we got disseminated intravascular, so inside the vessels, coagulopathy, right? So not only a like bleeding risk because we have low clotting factors, but also we're clotting also. So, and that's the reason why we have low clotting factors. We're consuming all of our platelets, right, to make a clot right here. You need the fibrin mesh, which is from the coag cascade up here, right? And you also need platelets, right? So so you keep making a whole bunch of clots, so all the platelets gets consumed, right? And all the clotting factors get consumed. If you have liver disease, you have a lot more issues on your plate, but that's going to be the underlying problem: excessive clot formation and excessive bleeding. And it's also, you remember, you have inflammatory and anti-inflammatory mediators. You have inflammation making the clots, and you have anti-inflammation breaking the clots down. So you played yourself twice. So you're making clots erroneously, but also you're breaking down clots. And you still have the inflammation there to make more clots. So we can actually measure how much clots have been broken down, and that's called a D-dimer, right? Or a fibrin degradation product. So this is fibrin mesh over here, right? If you break it down, that's a fibrin degradation product. It's a product of fibrin degradation, right? An FDP. Okay, not a failure to pace, but a FDP, right? So that is a problem with clotting. So we can do diagnostic tests. We can say, well, the D-dimer is elevated. That means we have too many clots being broken down, or breaking down a lot of clots, right? And fibrinogen, right? Fibrinogen generates fibrin, and fibrin is needed for what? Is needed for the clot itself, right? Here you got a fibrin mesh with all those platelets mixed in there, right? So are the platelets going to be low or high? They're also going to be low. Platelets are low, fibrin or fibrinogen is also low, that makes the fibrin. And we're breaking down the fibrin, so we get fibrin degradation products that are going to be elevated. All right, so increase D-dimer or FDP, decrease fibrinogen, decrease platelets, and increase coags. Coags measure the time it takes to make a clot. Right? If you don't have platelets and you don't have fibrin or fibrinogen, you can't make clots good, right? So the time it takes to make clots is to be increased, right? That's the prothrombin or prothromboplastin time from point A, PTT, to down over here, point B, right? Prothromboplastin time. Okay, so that's going to be high. INR will be high and PTT will be high because we're just consuming everything, right? And the only one that's elevated is is our coags because it's taking longer, but also our clot fragments, right? So how do you fix it? Well, the right answer is always treat the underlying cause, right? So you're still going to fix the sepsis. You're going to give the antibiotics. You're going to give the support the blood pressure, all those things. But the other thing we can do is give heparin. Well, shoot, they're bleeding. Why would I give heparin, right? Well, because they're making clots. And how do you prevent clots from being made? You give heparin, right? So you can't give it forever. If platelet count is less than 50, then you still can't give platelets. Or sorry, you can't give heparin because that's going to cause more complications. But in the early phases of DIC, you can give heparin to prevent the formation of clots. Okay, and then if they are bleeding, right, and they're bleeding, and the bleeding is ridiculous. You can see they got clots right there in the toes. They got bleeding everywhere, bruising. What are small bruises called? Petechiae, right? So you got petechiae, then you got ecchymosis, right? So you have widespread bruising because you have bleeding under the skin, right? We have bleeding all on different bony prominences. It's widespread clotting and widespread bleeding. Okay, so you got acute renal failure. You got clots in the kidneys. You got hematuria. So usually your patient looks like if they have like a central line or a peripheral IV, there's blood all around it and it keeps oozing. Like I changed the dressing twice today and it's still oozing, right? They're oozing blood everywhere. And of course the hemoglobin can drop, the platelets can drop, and of course this is a really bad situation, right? DIC stands for death is coming. That is usually the nickname for it. Okay, so you got thrombosis and bleeding. All right, you got bleeding out of the eyes, out of every orifice bleeds.